Now, my topic, as I hope you can see, is on current trends in the medical management of endometriosis. This is an extraordinarily complex disease, and I don't intend to just talk about the clinical focus of medical management, but I hope that I will be able to introduce that with some of the background and to fill in some of the necessary understanding about mechanisms and so on with this condition as a prelude to talking about how hopefully we can better manage many of our patients with endometriosis in a medical manner. I do need, nowadays, of course, always to start my lectures by indicating conflicts of interest. In this world, those of us working in anything academic and medical do need to declare our conflicts of interest, and we all have them. And I just draw your attention to the bottom one of these, which says, I believe that open academic collaboration between the pharmaceutical industry and individual clinical experts is essential to the future understanding of endometriosis, which is a continuing enigma of a disease. I was fascinated when I started to research the background of the extraordinary foundation which we honour today, and to find out about Dr. Steyer Paul himself, who has been the major initiator of the great majority of the major concepts behind this foundation today. This man indeed was a visionary first and foremost, an eminent industrialist, which earned him the financial backing to be able to do an extraordinary number of things here in India, and to set up examples which are a torch for countries all around the world. He has left a legacy of excellence. He is a role model for us all. And today I was most interested in seeing that he has, in fact, with his daughter, set up a university with a liberal arts background, but some very interesting focuses. Not surprising, in view of his background, is an emphasis on both engineering and business, but also on journalism and communication, critical issues in the modern world, but also design courses. And through all of this is a thread pointing to his particular awareness and interest in healthcare issues. I was intrigued to see that there is a Master's of Science in Clinical Research, a PhD in Biotechnology, degrees in Pharmaceutics and Novel Drug Delivery Systems, something that has always intrigued me, and a diploma in Pharmacovigilance, amongst other things. Very far-sighted. This is clearly an amazing man. I personally have been humbled by the invitation that I have to be here today, and I hope that I can raise sufficient stimulating issues for you in the spirit of excellence in clinical research and healthcare, which have been espoused throughout his life by Dr. Steyer Paul. So, I will try to focus a little on the challenges and to challenge your thinking skills. Endometriosis has often been called the enigmatic disease. If you look up the shorter English dictionary, there are a lot of different definitions of the word enigma, but in general, it means that this is something that is very difficult to understand, and this is perhaps of all the gynecological conditions the most difficult to understand in our present terms. This is still a mystery disease. in spite of much research, mainly so far done in the Western world, but I'm delighted to see increasing amounts of academic pursuit and attempts at understanding many aspects of this disease in the whole world. I see this as a suitable target for the philosophical ideals and the excellence in research principles purveyed by Dr. Steyer-Paul. Now, first of all, what is endometriosis? Endometriosis is the presence of tissue with histological similarities to the endometrium, but outside the uterine cavity. This tissue in these ectopic lesions is functionally and architecturally quite different from the endometrium inside the uterus. So this is not external endometrium. This is a different condition. These are different tissues. And additionally, the endometrium from women with endometriosis is also functionally different from the endometrium of women without endometriosis. And the genetic and the molecular pathway complexities are fascinating, they're unique, and they're the subject of major ongoing research programs. And I'm going to be very selective and demonstrate my own personal biases in some of the examples and the ways that I'm going to look at this condition. Endometriosis is an extraordinarily variable condition. It's variable in the age of onset, in the constellation of presenting symptoms. There is always a symptom complex that accompanies the pain or the infertility, which are seen as perhaps the two main symptoms accompanying this disease. It's variable in the types and the severity of pains that the woman describes, variable in the site, the type and the extent of lesions and their pathology. It's variable in response to treatment, in the rate of recurrence following even excellent surgery, variable in the molecular pathway activations and pathophysiology. And it's influenced by multiple gene activations and modifications. There is now a huge literature expanding almost daily on the genetic background of this disease, but it is still as mysterious as ever from the genetic perspective. And you will see these four letters, GWAS, frequently appearing in the genetic literature. These are genome-wide assays looking at gene activations within the tissues associated with endometriosis. And so far, they have just provided us with increasing complexity in terms of trying to understand the pathophysiology of this disease. But it would be very surprising if we don't see an explosion of fascinating data about this condition over the next decade. Now, there are a whole range of what I see as current issues in the biology of endometriosis. I've talked a little about the complex genetic susceptibility. For example, if out of any of the women in this audience, if you have a sister with endometriosis, you have an 8-fold risk of developing endometriosis yourself. That's huge. If you have a mother with endometriosis, then you and your sister each have an approximately 8-fold chance of developing this disease. So there is major familial influence on the background. There are external environmental influences. We know that reproductive events influence the appearance and perhaps the severity of the disease. There are changes in cell-mediated and humoral immunity, so not just local immune changes within the lesions or within the endometrium of women with endometriosis, but also in the bloodstream. This is a systemic disease which we have not really recognized as such in the past. Therefore, there are roles for the cytokines, the chemokines, and other molecular regulators released by immune cells and also other cells in the reproductive tissues. There are roles for angiogenic and neurogenic factors because vascular development, angiogenesis, and nerve development are clearly a part of this disease. There is a complexity of all the various different molecular mediators. We're only really just beginning to scratch the surface. There are factors responsible for pain generation, but again, we're only just beginning to understand their complexity. There are factors responsible for infertility. Almost anywhere we look, we find that the molecular disturbances could be playing a role in influencing infertility. And of course, we need then to start coming to the roles of different medical and surgical therapies. I would also draw your attention to a small number of thorny issues which we're trying to wrestle with at the present time. The first being that endometriosis is a chronic inflammatory disease. We've always known that immune cells were a bit disturbed, or numbers of immune cells were changed in the tissues affected by endometriosis. But little did we understand that this really is a chronic inflammatory condition where there are major changes in the immune system, both locally and systemically. There's also the concept that perhaps endometriosis may primarily be a disease arising from the endometrium, because the endometrium of women with endometriosis is indeed quite different in the way it functions and the way the molecular pathways are set up compared with the endometrium of women without the disease. We've talked about the differing genetic origins, the multiple gene disturbances. I've talked about pain processing, but it is complex and highly variable between individuals. There are indeed even a small number of women with quite severe endometriosis who may not experience any symptoms. They do not have pain that they recognize as pain, and fortunately many do not turn out to have significant infertility. And what is the difference between those and the women who have real problems? Not yet always clear. And if we then pass on to look at the different types of endometriosis, there is increasing evidence that there are probably 3 phenotypes, 3 different forms of endometriosis in terms of the pain and the symptoms and the infertility. And we start at the beginning. You can actually find pathological tissues within the peritoneal surface down in the pelvis in women who have no symptoms, but when you look in with the laparoscope, you see an apparently entirely normal peritoneum. If you do multiple biopsies and you have a good pathologist, you will frequently find pathological appearances of the lesions of endometriosis. So this can begin at a microscopic level. Whether that is a disease, whether it is an extension of a normal physiological phenomenon, which then needs to progress further before you can call it a disease, we do not yet know. But once we do meet our current definitions of endometriosis, that is the presence of these lesions in association with symptoms, we find that there is a disease that only affects the peritoneum in many women, the pelvic peritoneum usually. Sometimes that can go deeper and become more vascular, and that may then extend into deep invasive disease in the deeper tissues of the pelvis. Or sometimes, quite on its own, without any other type of endometriosis, you can get endometriotic cysts, ovarian endometriomas. And there is evidence that these are probably 3 different phenotypes of the disease, even though versions of all of them can be found in the same woman occasionally. So you can get combinations of the lesions. How do we compare and grade these lesions? Well, they undoubtedly influence the way in which you approach management, whether that management you choose is surgical or whether you decide that there is a place for medical management. So understanding this disease and its background is critical for deciding where we go in terms of trying to manage the disease. Those of you who've studied endometriosis will know that we generally try to grade it using the American Fertility Society recommendations, now taken over by the the American Society for Reproductive Medicine. But even though that gives you a really good reminder of what the pelvis looked like at your last laparoscopy, it does not help to predict how that patient will respond in terms of therapy, what her chances are of fertility, or any other aspect of the disease. And the only index that we have that does help to predict is the fairly recently described Endometriosis Fertility Index proposed by Dr. David Adamson from San Francisco. And that is a very useful index for women who wish to retain their fertility and hope to predict their chances. Now, if we take a step back and look at the pelvis and look at the pathology, which is where the classical understanding of endometriosis came from in the very early years of the 1900s. And this courtesy of my very good friend, Professor Robert Jansen, who we sadly lost earlier this year. He did an interesting study with one of our really good pathologists, trying to understand what was happening with the pathology of endometriotic lesions on the pelvic peritoneal surface. And in the top left-hand corner is a classical view of a red flare lesion, what we now know as a very active lesion with ongoing angiogenesis, so new blood vessels growing in from the outside. Those are the red stripes. In the middle is a reflecting white surface where there is already a bit of scarring developing, and we biopsy that area of angiogenesis, and bottom right you can see the classic appearances of both the epithelium and the stroma, which have great cellular similarities to the endometrium, but of course the architecture of the tissue is quite different from the endometrium. We can look at other areas of the peritoneum, and you can see right in the middle of this a little papule. This, in most cases, we think is probably the earliest visible macroscopic appearance of endometriosis. And if you biopsy that papule in the middle, on the right-hand side, you see the pathology with the epithelium and the stroma of endometriosis. And as I mentioned earlier, if you biopsy areas that are well away from the obvious lesion, perhaps at the very bottom of the left-hand part of that slide, where it looks like normal peritoneum, you frequently will find pathology suggestive of endometriosis. And in one study carried out in the 1980s, they found evidence of peritoneal endometriosis in 18% of women who were coming for reversal of sterilization. So these were women who'd proven their fertility previously, wanted to have more children, and there was no evidence of any other features to suggest they would have infertility, but biopsying the peritoneum in 18% of cases demonstrated microscopic endometriosis. So this disease is a puzzle from the very earliest microscopic changes, which may get worse, they may resolve completely. There's a little bit of evidence for both of those in some cases at some times. And you also need to think about how long does it take to develop endometriosis, even if you've got very strong genetic predisposition. And if you think about it, in a woman who has got a strong genetic predisposition, and if you think about the pathology of this disease probably being retrograde menstruation of cellular fragments, little bits of viable tissue that may eventually stick to the surface of the peritoneum and grow and form lesions, it must usually take many, many months of repeated exposure to these viable cells or viable fragments before the disease actually becomes something that you can recognize pathologically. And certainly somewhat longer, even though we can see the worst forms of this in women still in their adolescent years. Of course, with these 4 examples that I show you here, these are much more advanced diseases involving the ovaries and the deeper tissues of the pelvis. But exactly what influences these, how they're influenced, and how it then influences the choices that you make for medical management is something that we still do not fathom. The World Endometriosis Research Foundation has been very active in recent years, particularly at the times of the triennial World Endometriosis Congresses, and it has made major attempts to try and define how researchers into this disease can ensure that we all define the disease in the same way, that we describe it in the same way, and that we do certain things that are systematic from one study to another, so that we can compare studies and begin to understand this very puzzling and individually variable disease. The current gold standard of endometriosis, of diagnosis of endometriosis, is, of course, to use the diagnostic laparoscope and to biopsy possible lesions, and to have an experienced gynecological laparoscopist be the person who is looking down the laparoscope. We can get some additional information prior to laparoscopy by using transvaginal ultrasound, particularly for ovarian cysts, and with developments of the latest technologies and good quality ultrasound experts, we can begin to define, using both transvaginal, rectal, and even putting fluid into the rectum, to try and define the extent and the outgrowths of the deeper disease. Top right here, you see a classical ovarian endometrioma, and you see colour Doppler definitions with the colour streaks around the margin of that cyst, indicating that this is quite a vascular cyst. On the right-hand side at the top, you can see a lesion in the wall of the bladder that's extended into the bladder cavity. Bottom left is complex disease involving bowel, and on the right-hand side is, if I can get the arrow, you can see tiny cysts with modern disease, which may be important in terms of your planning surgical approaches. Anyway, what about the accuracy of our ability to diagnose this disease? There are now probably about 7 or 8 studies in the literature looking at how good we are at diagnosing this disease, and they come out with very different positive predictive values as to how good we are at looking down it. And those values vary from 25% up to 100%. And this is in a good systematic review. And if you look for histological proof of disease that has been visually diagnosed as being endometriosis, even the best experts cannot get better than a 75% accurate assessment of lesions on the surface of the peritoneum. We're not very good at it. One study done in Italy, but also part of it in the United States, got 3 experienced gynecologists who looked at 91 lesions, and they each looked at the 91 lesions, and they each made their note as to whether they thought it was endometriosis or not endometriosis. And the guy who did worst only got 42% of those lesions right when he looked at them through the laparoscope. The best one got 76% right. And in another study, where 5 gynecologists experienced at laparoscopy looked at 1,439 lesions, they found that they, between them, did not get better than 50% in assessing peritoneal lesions. But they were much better, around 80% accuracy, for more serious, more advanced cases of the disease. So we're not good at picking peritoneal endometriosis and distinguishing from other variations in the macroscopic appearance of the lesions on the pelvis. And in fact, in that last study, they concluded visual diagnosis of endometriosis is generally unreliable as a primary diagnostic method because at least 1 in 4 biopsy specimens in our study did not meet the histological diagnostic criteria. So in order to assess this disease, you need to biopsy peritoneal lesions, but you may be much better